Good evening, everybody. Welcome to our fourth Willows Academy webinar. Fantastic to have you all join us during this really warm, sunny Thursday evening. So just a few house rules before we begin. So we're going to be recording this webinar on YouTube. So if you could keep your cameras and your microphones shut during the course of the webinar. So today's webinar is going to be on older people and COVID and the lessons that we can learn from the first wave. So one of our missions at Willows Health is really to improve the quality of care we're giving to our elder people. And part of that mission means that we're really privileged to have someone of the stature of Dr. Richard Wong join us at Willows Health to really try and improve the care we're giving. And perhaps that will help us to interface between primary and secondary care services. This has all been really apt in terms of time because coronavirus has impacted elder people disproportionately. And I'm hoping we can look at the figures and dissect all the questions that we had posed during the trailer. So without further ado, I'm going to introduce Dr. Vinay Gupta. Dr. Gupta is one of our GP directors at Willows Health, and he has worked really closely with Dr. Richard Wong to transform the way we are delivering elder people's care at Willows Health. And I'm hoping we can even look at some of the qualitative and quantitative figures which show the result of that work. And we also have Dr. Richard Wong, who's been a consultant geriatrician with University Hospitals of Leicester for many years and is now Clinical Director of Older People Services at Willows Health. It's a privilege to have you both join us today. And without further ado, I'm going to pass it to Richard and Vinay. Thanks, guys.
Okay, so thank you very much for that lovely introduction, Tariq. I mean, I think it sets the scene really nicely, actually, for what's hopefully going to be a really useful and helpful discussion about a topic that I think is exceptionally important when we consider our overall response to the COVID outbreak. I think we're at a stage now where actually it's quite possible and almost appropriate to sit back to some degree and reflect about what the last few months what's happened in the last few months. I think a few words that Tariq, you yourself have used in past webinars and words used by the wider public and media to describe the responses of various sectors to the COVID outbreak, sectors such as the health care sector, the education sector, the care sector. Some of the words that have been used have been really quite encouraging. So words such as versatility, flexibility, commitment, dedication, and compassion. And I think it really has been quite admirable to see how so many organisations have responded so positively to what has been a real, in many ways, a very uncertain and unprecedented situation. Naturally, with something like this, I think it's only inevitable that there would be various challenges that would be faced by all of those involved. And I don't think there's a better group to illustrate that than when we think about the COVID outbreak in the older population and within care homes. I think there are some really important lessons that we can learn from the first wave in this group of individuals. And this is very much the focus of today's topic. And as Tariq very correctly said, you know, we're absolutely delighted to be able to welcome someone as well known in this field as Dr. Richard Wong to speak about it with us. So it's been a real pleasure to work with you, Richard, about in sort of many of the initiatives we've been doing within Willows Health. And if I could please just start off with my first question. Okay, so if we could please get the slideshow up and then we can start. Thank you. Okay, so Richard, I think the first question, quite simply, is could you tell us a bit about how severely affected the older population have been by COVID?
Sure. Thank you for that kind introduction. I'm just good. So thank you for the kind words. Can I just first two things here in line with all my colleagues in geriatric medicine at Leicester Royal Infirmary. We have had our clinical experiences, and I'm going to try and bring that to bear in terms of what I'm going to talk to you about. So there's no doubt that you know, it's been publicised with coronavirus that there have been some particularly adverse outcomes in younger people, but despite this, it has been predominantly a disease of older people. I'm just going to get my first slide up. So this slide was taken from data midway through the pandemic by a national collaborative research group, and I think you can see at a glance how there's you know, at each age group, increasing age group, there are higher numbers of people requiring hospitalisation with COVID infection, and a higher number of deaths from these. And when I say at an increasing age, I think you can see from this, actually, you don't even have to be that old. I mean, many of us will start to get worried when you see the figures starting to really balloon up around the age of 50 onwards. By now, you know, we've got more than 41,000 deaths nationally, and the vast bulk of these, more than 90%, are in the over 60s, with a real condensing of these in the much older age group. And this is mirrored in the local COVID deaths with Willows Health, much smaller, but a very similar proportion, as you can see. If we compare internationally, this is the data from China, from their CDC, and you can see the case fatality rate at each segment of age, and it mirrors very similarly what has been happening in the UK and across all countries that COVID has affected. Now, you might well ask, you know, why is it in the older age group, particularly, you know, you don't even have to be that old really to suffer with all these problems. This slide was shown in the first webinar of the series, which Professor John Bennett spoke at, and it shows what we understand to be the phases of the COVID infection, from the initial viral replication phase, and then how the body responds to that with the immune system. And I show this really to perhaps illustrate one of the multiple reasons why the older age group are affected. I mean, clearly there is a higher comorbidity rate amongst older people, whether that's overt or hidden, particularly things such as diabetes, hypertension, coronary artery disease, and those factors have something to do with the increased rates in older people. But also, I'm just going to focus a little bit about the immune system and talk about innate immunity and adaptive immunity, which coincide with the with the phases of the viral infection. So when the virus first gets into the nasal passage, into our upper airways, and is binding onto the cells and multiplying, there is the natural barrier functions of our body, the mucus layer, the structure of our airways, what the integrity of that is, which acts as a preventative barrier. And then you've got patrolling cells, things like natural killer cells, which come and mop up at the surface. This happens in all of us. As we get older, these things do weaken because of structural problems and because of immune problems. And then we get our second phase, where the immune system is latching on and actually starting to identify and have a much more targeted approach to the virus, producing antibodies. And this is where we get the range of inflammatory chemicals we call cytokines, and what's been called the cytokine storm that may cause a lot of the multi-organ and multi-system damage with COVID and the lung distress. So those factors may get worse with increasing age, partly because, if you like, the body as we get older might be seen as being in a higher state of inflammation due to factors such as atherosclerosis and other inflammatory states in the body. And it may be that due to genetic factors and these acquired factors of bodily inflammation, that there is a higher event rate in older people. So what we do know is that increasing age, increasing severity of your illness at presentation, and increasing comorbidity increases mortality with COVID. What we expected to see was that the more frail you were would also increase your mortality with COVID. Now, this is where we've had a bit of a surprise lately. I'm going to walk you through the next slide. This is quite a busy slide, so if you bear with me and I'll walk you through. First of all, I'd just like to acknowledge my gratitude to my colleague, Professor Simon Conroy, who's allowed me to show this data of his and his research group from Leicester, as yet unpublished. This is single centre data, and if you stick with me on the bottom slide, I'm showing you these are different categories of frailty, and as we move downwards, there's increasing frailty, and this is your survival after attendance at the emergency department with time. So as you can see, there's a high attrition rate, particularly in the very frail, which happens quite early, but even in what we call the severely frail, by about 1 year after an ED attendance, you've got an almost 50% chance of having died. That might be due to multiple admissions and then dwindling, or catastrophic events with one illness, but it shows you the mortality. And we expected a similar relationship with COVID. I'll just reference the clinical frailty scale, which is what we're using now as a standard way of identifying degrees of frailty. We would call moderate to severe frailty 6 and upwards. When we looked at the cohort during the pandemic, who were coming in when Professor Conroy's team looked at that, what they found was this relationship held true, similar to the survival pre-pandemic. So if you were in the mildly frail category, you had a higher survival rate than those in the more severe frail categories. With COVID, that trumped everything. Whether you were frail or mildly frail or very frail, the outcomes were very similar. It was much more dependent on age and those other things I've mentioned, such as disease severity at presentation and comorbidities.
Okay. So, I mean, thank you for that, Richard. And I think there's some really striking statistics there. And I think it really illustrates from a local, national and international perspective just how significant the scale of the problem has been within the older population in terms of infection rates and mortality rates. I mean, I find it very interesting that even taking a small subset of our own COVID deaths since April 2020 at Willows Health, taking that subset of 27 deaths, actually, sort of, if you split it up in terms of demographics, it actually mirrors the national and international picture quite closely. I mean, one thing that was quite sort of apparent, particularly from the first graph that you showed, is that at all sort of age groups, there seems to be an increased risk of mortality from COVID, simply conferred by male gender. Do we have any idea why that might be the case?
That's a good question. I don't think there's any simple answer to that. I think it's probably a multiplicity of factors. People have proposed higher rates of comorbidities in older people, in males versus females, particularly cardiovascular disease, high rates of smoking and lung disease. But even when these things are corrected for, males still seem to come out worse. People have even proposed that males are less hygienic and don't wash their hands so much. So there's a wide variety of propositions. One of the things that's gaining some interest is, again, looking at this idea of COVID having your genetic makeup having some bearing on your COVID outcome, is that women may be genetically predisposed to have better outcomes because a lot of the genes coding for immunity are on the X chromosome. Of course, women have 2 X chromosomes. I kind of joke this is why women do survive the flu better. Men always have terrible man flu because we've only got 1 X chromosome. But the fact is, women will have 2 copies of an X chromosome in their cell. Of course, only 1 will be active, but they will have access to a wider array of immune-related functions through that. And also, interestingly, the ACE2 receptor, which the coronavirus binds onto, is coded for on the X chromosome. So people have proposed that in men, you've only got 1 type of ACE2 receptor. In women, the cells could express either or, and that might just present a slightly bigger hindrance to coronavirus binding.
Okay, So obviously sounds like there are a whole multitude of possible factors to explain, why male gender would confer an increased risk. I mean, I similarly, and I know we've spoken about this, was very surprised by the study to do with frailty and the fact that frailty on its own didn't seem to confer an increased risk of mortality, because from a logical almost point of view, we probably would have thought something quite different. I mean, I think one thing also, Richard, just to illustrate the scale of the problem, one thing that's been very topical has been very much the scale of the problem in care homes. So do we have a bit of data maybe surrounding that we can maybe share with everyone?
Thank you. Yes, I think it's probably best to devote quite a bit of focus on the care home aspect. It was in the flyer, and it's certainly been very well publicised. I took this data from The Sun, which is actually probably the best graph for this infographic, really. It shows it very nicely. And in this, you can see on each day during the pandemic, total deaths from COVID in the UK. The green is deaths in hospital and the amber are deaths in care homes. There's a smattering elsewhere. And I think you can see that deaths in care homes started to be identified relatively late in the pandemic. Now, this might be due to lack of testing at the beginning, or it may be that the virus was transmitted into care homes belatedly through a hospital to care home transmission link. But the illness genuinely started in the community and then went to hospitals at the beginning of the pandemic. As you can see, on certain days, it was almost matched the number of deaths in care homes compared to in hospital. And bearing in mind, again, the difficulties in getting access to testing in the community, this may be an underrepresentation. If you look at excess deaths in care homes, you may add another few thousand to that number. So that, all in all, we don't know exactly, but somewhere between 30 and 50% of COVID deaths in the UK may be attributable to folk who are in care homes. And this number is not unique to the UK. This figure shows deaths from COVID in the bars, and that refers to the left-hand vertical axis across a number of countries. And the blue circles are the percentage deaths, which refer to the right-hand vertical axis, percentage deaths of COVID in care homes. And you can see most of the Western economies fall around the 30 to 50% mark. There's a few exceptions elsewhere, but most of the Western countries are at a similar level. Okay.
So, no, I mean, thank you. I think that illustrates the point to do with care homes. And again, even when we looked at the 27 deaths since April 2020 at Willows Health, it actually mirrored this picture quite closely. I mean, I think in a global pandemic such as this, it is useful to compare countries and outcomes. I mean, I think very much so we can share learning across countries and look how the different approaches in the different countries may help us to actually shape our own future actions. I mean, a lot of people are predicting a potential second wave. It seems quite clear from the graph that the proportion of care home deaths sort of amongst the Western countries was relatively similar. I mean, for other countries, I mean, say Hong Kong, for example, which is right on the other end of the scale. I mean, are there any reasons or differences of approaches from these sort of countries which might account for their seemingly low, very low mortality rates in care homes?
Yeah, thank you. That's a good question. And, the heads of the health sectors in the Far East have been called to explain their findings to the UK government because of these stark differences. I think the Far East obviously had to deal with the SARS epidemic more than 10 years ago, which was the first coronavirus. And so they've obviously learnt from that. They've had much more responsive approach to the pandemic in terms of locking down early, not allowing visitors, and even trying to reduce care home to hospital transfer of patients by increasing the provision for community visiting in Hong Kong. And Hong Kong's been particularly aggressive with this. And even if someone was identified as having coronavirus in hospital, they were quarantined before being allowed back to the care home, sometimes for up to 12 weeks. So, very, very radical measures to tackle this.
Okay, so that's really very interesting, and it sort of, you know, obviously seems that having had previous experience of similar kinds of outbreaks quite naturally has helped some countries maybe prepare for this in a different way. I mean, one other thing, I mean, it does leave the question that obviously the different approaches in different countries and a national response to a pandemic such as this, there's obviously a large variety of different factors at play to determine that kind of response. It can be political factors, cultural factors, and lots of other things, but it is certainly worth sort of bearing this in mind. So sort of moving on a little bit, Richard, I mean, I think it'd be quite important to consider what some of the challenges and maybe some of the more practical challenges were faced by care homes during the first wave and by sort of the older population in general.
Thank you. So I think the problems of obtaining PPE in care homes, testing availability, testing turnaround times have been well publicised in the press. I won't focus too much on that. What I will talk a bit about is the idea of negative tests and whether this might have caused some confusion and complication potentially. We do know that turnaround time for tests has sometimes been several days, and at the beginning of the pandemic, sometimes even longer than that, which means that if someone was tested negative to return to a care home, by the time the result was received, they may well have contracted the infection. And this was outlined in a recent BBC News report. Actually, it's quite close to home, where people returned back to the care home and were actually the beginnings of a mini outbreak. So the other aspect, of course, is these tests are difficult to do. There is an inherent, they're not 100% sensitive, and in fact the insensitivity means that you're going to get 1 in 4 to 1 in 5 false negative tests from a nasopharyngeal swab. In the older person who may be less compliant, that might potentially increase. And that might have implications for what actually a negative test means, or whether we can even test in some of these people.
Okay.
The other things that have been well documented have been some of the issues around DNA CPR and escalation discussions, which have been done en masse by health professionals at the beginning of the pandemic. These were well publicised, and there was certainly a very negative media reaction to this, which was perceived as rationing of care by age, even if there was at least some intent to try and do holistic care in this.
Okay, so no, thank you, Richard. I mean, obviously the issues of PPE and testing are very well documented, and they've been key topics when we're thinking about how we've responded to the overall outbreak. Perhaps maybe sort of after we've completed our bit of the webinar, that might be something we want to discuss further about potentially alternative strategies or what could have been done differently. I mean, coming on to the care planning idea, I mean, I think this has at times certainly made it slightly harder to plan proactive care for patients. I mean, as sort of clinicians, and again, I know we've had various discussions amongst ourselves and with lots of other different clinicians, we sort of know even in normal circumstances, these discussions sometimes can be quite challenging and quite difficult to do. I mean, do you feel that in some ways, kind of in the midst of a global pandemic, which often induces fear, do you think in some way that's not only made the discussions of these sorts of things much harder, but actually the reaction to it from sort of, you know, some of these hard-hitting newspaper headlines and things almost inevitable?
Yeah, I think, as you say, coronavirus produced such strong emotions, fear, anxiety, and it probably wasn't the wisest move to try and do something en masse. It was always going to be seen as care rationing. I do think this has really illustrated what we need to be doing in times of relative peace and calm, and we can talk a bit about that perhaps later on. But clearly, these are things that, if they're not done beforehand, they end up getting done in a chaotic and stressful situation in the emergency department, and certainly myself and my colleagues have seen that numerous times, and it's not always been the easiest there. So it's all about maybe better planning for these things, but we'll come to that perhaps a bit later on.
Okay, yeah, I mean, I think some of the sort of messages that are coming through is that actually these things have to be done at times, but actually doing it in a timely and sensitive manner and making them quite personalised can be very important. Just staying on the themes of challenges, I mean, were there any other major challenges faced in dealing with the outbreak?
Yeah, so I think the other thing I just want to draw attention to, I touched on it with the infographic from the Sun, which showed the deaths in care homes, is really the problem of, I'm not sort of trying to sort of cast blame on any organisation or any or the government. I think it was genuinely difficult to know how best to try and stop this problem in the care homes, and we've had various thoughts about not allowing these people or trying to reduce admissions to hospital so that they don't catch coronavirus. There's been unclear and changing strategy about what is required to get them back from hospital to a care home, varying from initially, as long as they can be contained and there's PPE, they can come back with a positive status, to now need negative swabs. And I think this has all caused some confusion. You just need to be aware that once coronavirus gets into a care home, looking at a cohort study in North America, admittedly at the beginning of the pandemic when people were still finding their feet, 3 weeks after the first index case of coronavirus, 2/3 of the residents tested positive. So, it spreads quickly. And I think this shows you the discharges going from hospital along the top, and at the onset of the pandemic, fewer people were being discharged either to care homes or to any other location because people were more unwell, they were dying or they were staying in hospital. But what you can see is that pre-pandemic, just before the lockdown, there was a kind of, numbers are small, referring to the right-hand axis, jump from about 2% to a peak of about 4% of discharge to care homes. And this references the move the government made to try and encourage bed space in the NHS. People were fearful that the acute hospital beds would be saturated and overrun. So there was an attempt to clear things. And I think probably more people moved to care home placements around that time than we were used to, and many of them may have been harbouring silent infection at that time. So I think this cycle of breaking the transmission from hospital to care home is quite crucial as we look at that, and that's one thing that the Far East has achieved very well. The other difficulties have been in the presentation of older people, particularly frail older people. The presentation is well publicised, and what we do know is that we have seen a wide range of presentations in frail older people, and perhaps we shouldn't be surprised because we've always said that it's quite typical for frail older people to present atypically, if you like. So, it's been estimated that about 1/3 of the frail older people will be presenting with things such as abdominal symptoms or even asymptomatic, or just change in behaviour, confusion, or even balance, postural problems. So these have been documented and have made it difficult to actually try and track and trace the spread of infection in care homes, because we've more or less thought this is like a flu pandemic where people will have symptoms recognisable and will test them when they got symptoms, but actually they may have other symptoms or may be asymptomatic, and the asymptomatic carriage rate may actually be quite high.
Okay, yeah, so really, it comes across, and I think it leads into the case you're going to present, and it really kind of suggests, and it's quite important to know how COVID is presenting in different cohorts of the population, and the fact that there's such a degree of variability of presentation in the older patient, and really a large degree of asymptomatic carriage. It almost suggests to me, as you kind of alluded to, that even with a very stringent organized testing program, it may have actually been very difficult to implement, because it would be quite hard to actually know which patients we would actually need to test and which group to focus on. I mean, just coming on to it, and I think you are with this case, I mean, what are your own personal experiences of variable presentations in the older age group?
Well, what I would say is that it may be best if I share the case history, and then actually that will help me maybe to share with you some of my thoughts on this. So these are all real cases, and these are all from Willows Health. This was a 99-year-old lady who was in a care home. She's very frail. She doesn't really walk, dependent on assistance and wheelchair, and she's got multiple comorbidities, as you can see. And she had multiple chest infections. I think she had one only several weeks before the index admission to hospital. And what happened was that she was generally feeling weak, and it's recorded on the system that she just didn't sound right to her family on the phone. They obviously couldn't visit. They said she just doesn't sound right. She was nauseous, wasn't eating or drinking much, and she said, "I want to go to hospital. I don't feel safe here." So she was sent to hospital. Interestingly, she had a care plan. Care plan was to try and treat her in the community, but it did say that if hospital admission was being considered, it should be discussed with a GP. And in her case, there was a discussion with a GP on the day of admission. And when she was admitted, she was drowsy, dehydrated, with worsening kidney function. But this is where you need to note, she didn't receive a huge amount of high-tech intervention. She got 1 litre of IV fluids, and I looked after her in hospital. And her diuretics were stopped for a heart failure. And by the next day, she was back to baseline. The blood results had almost improved back to baseline. Now, she was given a complete course of pretty, double antibiotics intravenously. More at that stage, I think, because we were treating everything belt and braces. But her CRP only peaked at 28. She never mounted a fever. Okay, and that's despite her chest showing some airspace shadowing, but she never needed supplementary oxygen. The OBS were normal throughout, apart from a bit of a tachycardia. So she stayed in for over a week, so that was only to have IV antibiotics, which, it's doubtful whether she needed that full treatment regime. I think what this illustrates is how atypical the presentation can be, and how she was frail. You might well say she was probably marked out as someone who probably wouldn't survive, but she did survive. And I understand she's doing quite okay at the moment. She's still frail, but she's probably not a huge amount worse than when she first came in. And this is what we've seen. We've seen frail people come in and have a minor impact or no impact, and we've seen frail people also deteriorate. And I'll come on to that maybe with some of the later case presentations.
Yeah. Okay. That's very, very interesting indeed. And obviously from that case, it illustrates a lot of things we've talked about to do with frailty, and that not necessarily having an impact on the mortality risk from COVID. I think what it highlights to me as well, and you brought in the fact that the GP had that discussion with the patient as well, or the patient and the patient's family, possibly, that care planning and care has to be very personalised. And actually, by relatively what we would classify in the medical profession as relatively simple interventions in the secondary care setting, there was a successful outcome. And actually, it kind of brings together the idea that maybe with the correct kind of organisation and resources, some of these interventions could even be brought into the community setting. But obviously, that's that's something that we would probably have to discuss further. I think sort of, along with the challenges, though, we have definitely found that there have been certain things that have been very helpful during the first wave of the pandemic. So can we just briefly go through those, Richard?
So I think, although obviously there have been some advances in terms of the findings of the benefits of dexamethasone and to a lesser degree remdesivir, really it's the key things are the actual basic measures of shielding, social distancing, reducing transmission through those routes, enhanced hygiene. I can't stress that more. That's probably been the overriding thing to contain the traps of the pandemic. The other things that we found helpful, and partly by default, have been the use of technology. We've used this both to help with the well-being of our patients because they've been isolated in hospital or care home, so using that to keep them in touch with their loved ones, and also using it for remote technology for remote clinical assessments. which has almost been thrust upon us out of the blue. It might have been something that we were thinking about beforehand, but suddenly our hand was forced. And I think people have been doing this to on a much wider scale than before.
Yeah. I mean, I think what I take from that is obviously the basics have remained very effective to control the outbreak. The basics that have almost been drummed into us from the start of social distancing and shielding. Technology, I find a very interesting one, actually, because I think building upon last week's webinar as well, I mean, I think it's something that's been almost hugely accelerated by COVID and the outbreak in terms of its use within the healthcare setting. Now, I completely understand its role in helping reduce the isolation of older people, particularly who may have had to socially distance or isolate themselves from their loved ones for kind of extended periods of time. Just thinking of it from a more clinical point of view as well. I mean, using this remote technology or various types of remote technology, obviously it requires good kind of, if you like, a good relationship or a good understanding with the care homes or maybe the carers of some of the older people. But if you have an older person who might be COVID positive or suspected COVID positive, are there any real signs that we should be looking for, even remotely, that may be a marker that they might go on to deteriorate or need further attention?
I think as the my previous slide showed with the variable symptom presentation, it's actually very difficult. But what it has probably trained our minds more is to try and work more closely with our care home associates, our colleagues in the care home sector, in terms of working out how we can identify and have a more rigorous approach to looking for these so-called soft signs of deterioration, which is very often what it has been, you know, a change in behaviour, and these things are probably recorded, and we just need to be able to tap into that information better. And I think that's a piece of work that probably, you know, across LLR, things that we should be looking at. How do we get access to that information? What are the key things? There actually are some tools which are promoted by the British Geriatric Society, something called Restore 2, but they really highlight the things that we should be looking at that I think you and I know about, such as, you know, reduction in food intake, less energy, less physical activity, change in behaviour, these subtle soft signs as pointers.
Okay. So, I mean, I think moving on to probably one of the final parts of the presentation, and then obviously we can move it to questions, is the idea of care planning. Now, this is obviously something that we've mentioned a few times, and we have talked about the challenges of doing it in the midst of a pandemic. And it's also something very close to kind of our hearts. I mean, something we've been trying to work on quite hard within the organisation, as Tariq almost mentioned right at the beginning. I mean, I think actually to illustrate it, you prepared a couple of really interesting cases where care planning was quite prominent in the overall care of the patients. Could I just ask you to run through those, and then maybe
I'll be very brief, because I know that we're running over, so I apologise for that. So this first two cases, very briefly, they're both in care homes. This lady's got some mental health problems. She's physically very frail. She's having recurrent falls, and in fact, she was going to be referred to the falls clinic pre-pandemic, but because of that, actually, it was you and myself were sitting in, and we thought we'd do a video consult on this lady to see whether there was anything obviously reversible. And she appeared to have some extrapyramidal problems, probably related to her mental health medication. So we advised seeing whether reducing that would help to some degree. But ideally, I think we both figured she doesn't have a care plan. She's pretty frail. Something might happen pretty soon. So we encouraged, we said we'll put her in the pipelines, that we'll get in contact with the family and try and discuss care planning with them. Now, the next day, she became suddenly unwell, and this shows you how quickly things can take a hold. She was quite chesty suddenly. We thought she might have aspirated, but we did say get a COVID swab, and 4 days later the COVID swab came back as positive. Now, one of the doctors did have a care planning discussion with her son, but already things were getting quite to a degree of stress. She had a positive diagnosis, she was unwell, it was all quite new, and I think there was a genuine struggle for a mutual stance on what her best interests were. Now, 2 days later, I was on call for Willows, and I received multiple phone calls. One of those typical afternoons on a Friday, I got a phone call at the same time from the care home, EMAS, her son, and my ED colleagues at the Leicester Royal Infirmary, who were all phoning about the same woman. Apparently she had sounded more chesty, the OBS were abnormal, although when the EMAS rechecked them, they were all normal, except a slightly increased respiratory rate. And this EMAS said, look, she's stable, she's not in distress. And we made jointly a best interest decision to give her best supportive care at the care home on oral antibiotics. But 2 days later, rapid deterioration, and she died. So this, I think she's shown, sadly, the rapid response that some people have to the virus. And it also shows, what happens when the care planning is perhaps not done well in advance. On the other hand, this lady in a different care home with Parkinson's and dementia, very frail, the care planning was put in place over a year ago. So by the time she was diagnosed with COVID, and the thing to illustrate here is that the home kept asking for a swab from PHE, and it took them 3 weeks to get hold of the swab from PHE, which confirmed COVID, and she died the day after that, unfortunately. But she did have a peaceful death because everything was well communicated in advance and people knew what they were going to be doing after this, with the onset of this illness. She also illustrates, in opposition to that 99-year-old I mentioned before, this lady was frail, and she had the dwindling that we see with some of our frail older people who get any infection, whether it's a urine infection or chest infection, where she became more delirious, reduced communication, what we call hypoactive delirium, reduced oral intake, and she just never really recovered, even with good supportive care. So
Okay.
variable outcomes in response to the infection in the frail older population.
Yeah. So, I think really, obviously, moving on to the actual idea of care planning, there are obviously lots of benefits, not least obviously providing a holistic assessment of the care of the patient. We've sort of gone into the idea that it can be challenging at times. It's very difficult, obviously, to do a whole teaching session about care planning. But do you have any sort of top tips from your vast experience of doing these conversations of some things that might help?
Yeah, I think the first thing is we shouldn't see this as just care planning in isolation. It's a stimulus for whole care review, which is really and we want to try and have some mutual understanding between ourselves and patients, relatives, about the condition and aligning aims. So, whole care review might involve seeing whether there's any acute unmet needs. And this is a nice tool if any of you want to have a look at the Scottish palliative care guidance. And there's this tool called the REDMAP guidance, which is an acronym for ready. Can we talk about your care? What do you want to talk about? What do you want to ask? Do you want to ask about unmet needs? Is your pain not controlled? Do you feel your long-term conditions are not adequately supported or managed? Do you need extra help? Is your medication too burdensome? So all those sorts of things. Then we can talk about diagnosis, what matters to you, and ultimately what actions. But these are not easy things to do, and they are emotionally draining, stressful, and they're best done at times when there's no other stresses on the situation in general.
Yeah.
So I just focus, we need to make these very personalised because, and you mentioned that earlier, and it's absolutely what this is about. So for some people, it might be a trial of IV fluids for a few days in hospital. It's absolutely reasonable. But if that doesn't work, we accept there is not much more we can do. It's absolutely making this personalised.
Yeah. So, I think, look, that really brings through the ideas of having sort of personalised care planning in sort of relative times of peace can obviously be quite beneficial. And what we try to also do as an organisation is analyse various patients who may have died both in the pre-COVID era and during the pandemic itself, and actually seeing, what some of the benefits may have been of those that had care plans actually. So looking at the pre-COVID era, in the 6 months between October 2019 and March 2020, we analysed 162 patients who had died across the organisation. 81 had care escalation plans and 81 did not. Very interestingly, for the 81 with the escalation plans, 78%, so a very large proportion, actually went on to die in their preferred place of death. For the 81 without escalation care plans, 56% died in hospital. looking at the COVID deaths that we mentioned earlier. So from April 2020 to the present day, across Willows Health, there were 27 COVID-19 related deaths. Just to put that in perspective, in the same time period, there were a total of 86 deaths of all causes. So it accounted for about 30% of the deaths we saw. Interestingly, only 37% of these had care escalation plans, and 17 patients, translating to 63%, didn't. Again, though, of the 10 with escalation plans, 70% died in their preferred place of death. We've included the bottom part just to again illustrate that actually in the midst of a pandemic, there were unfortunately 2 patients that we had identified who would have been suitable for the care planning discussions, but when we actually contacted them to initiate these discussions, unfortunately both of these patients had already contracted COVID, had deteriorated quite acutely, and actually they'd already been admitted into hospital where they subsequently died. So these were 2 where maybe there may have been a missed opportunity for care planning. Just quickly focusing and dissecting this data a bit more. I mean, it became quite obvious to us that obviously, particularly within the COVID deaths, there were a fair number of patients that didn't have care plans, but actually looking into the detail a lot further, actually, a lot of them certainly wouldn't be the kinds of patients that we would identify using various sort of age and frailty markers to maybe have these discussions with, which kind of gives rise a lot to some of your other ideas, Richard, you mentioned earlier, that actually the overall outcome or adverse outcomes from COVID perhaps affected a slightly different cohort of individuals than we initially thought it would have. One thing that was very striking, though, is a very strong correlation between having an escalation care plan and actually achieving the preferred place of death. And this is something that I think can't be emphasized enough, how powerful this can be. I mean, from a clinical and clinician point of view, I certainly know it can be, you know, some of the most rewarding work we can do to help a patient achieve their preferred place of death. From the other perspective, a family or individual or carer point of view as well, sometimes, I think absolutely it's one of the things in medicine that really can help restore the trust and faith in the profession as well. So I can't really emphasize enough just how powerful this can be to achieve. So I think really that's it from us, and apologies, Dorrit, we went slightly over time, but there was quite a lot to cover in what is such a vast topic. Just a few very quick take-home messages, Richard, if you may, and then we'll hand the floor back over to Dorrit.
Okay, so I will just focus in my summing up that really, particularly with regards to care homes, I guess we do need to rethink what is the hospital to care home strategy, how can we reduce infection risk, and look at testing improvements. Are there other ways of testing, including saliva testing, which is easier to administer? Can we improve care home support, whether that's visiting or digital healthcare, to try and break that cycle of infection, and just to get ahead of ourselves in relative times of peace for care planning. Thank you.
Hey, thank you very much. Back over to you, Tariq.
Guys, really fantastic. That was really useful. I think it really helps us to inform how the work we're doing with respect to care plans translates to outcomes. I think there's a couple of things that really sort of struck me in that presentation. Firstly, that the frailty score wasn't as important as age and comorbidity, but also that the Kaplan-Meier survival analysis shows that patients who arrive at the front of ED are likely to die within 1 year of that presentation. If you combine that with the data which shows hospital to care home transmission, it really makes us think about the implications of admitting care home patients into hospital, because we really want to do a benefit to our patients. And there's even an argument to say ethically that we're actually causing more harm by admitting care home patients to hospital than keeping them within the care home setting. And within your summary there, Richard, you did mention about some interventions and some changes in the way that we manage this group of patients. And it seems there needs to be a real need to have a facility and a resource whereby we can manage these patients in a care home without admitting them to hospital.
Absolutely. I think things such as being able to give subcutaneous fluids more easily in the care home, because it's still very novel, and I've been rejected for this, which I understand is the governance of a private organisation, but this is something that the whole health community needs to work towards, because otherwise probably the only thing you can do is to admit them to either a community hospital or acute hospital for such interventions.
Thanks, Richard. I suppose we also need to address the challenges of keeping people within the care home. And certainly some of the patients that we've jointly dealt with, there have been challenges because there have been cultural expectations to continue invasive interventional care. And there seems to be that we need to do quite a bit of work when it comes to educating our communities and what hospital admission truly achieves. I was really interested to hear in that first case example where we showed that admission into a hospital setting where the patient was given 8 days of IV antibiotics was then discharged, but actually when you look back from a medical perspective, there wasn't actually much intervention done for that patient. But if you look at it from the patient's relative's perspective, the patient was admitted, they had intravenous fluids, they had a consultant ward round every day, they had IV antibiotics daily, and perhaps we need to sort of work in changing that culture, and that's going to require quite a bit of work. Vinay, what are your thoughts on that?
No, absolutely, Tariq. And I think that's actually, in terms of actually understanding that interface between the primary and secondary care, that's going to be absolutely crucial in doing a lot of this. I mean, I think one thing that really was brought forward by that case also was how personalised you do have to make a care plan. So from that point of view, I mean, obviously having someone like Richard working with us who understands, if you like, both sides very well, what happens in hospital, what happens in primary care, it almost joins the system together. But I think from that point of view, you're absolutely right. Having those discussions, though, quite openly and honestly with patients about what might happen if they were to go to hospital or what the options might be, actually often opens up a whole number of different things that you get back from patients and their families. So no, I totally agree. It's very, very important, but it is obviously going to take quite a bit of work to address some of those cultural challenges.
And also, thanks Vinay for that, and also about the interventions that we can give to our care home patients. So we have Dr. Willows talking about oxygen in nursing homes, and it just makes you wonder about those simple interventions that we could perhaps more readily provide. Oxygen therapy, subcutaneous fluids, dexamethasone in care home patients. Is there a role for dexamethasone at the point by which a patient develops respiratory symptoms, Richard?
So I'm probably not the expert on this, but the published data so far is that it's useful in those who require oxygen support. Sure. So certainly if you were going to combine an arm and someone was hypoxic and required oxygen support and that could be provided, then sure, dexamethasone may be a beneficial adjunct, and it can be given orally.
Thank you, Richard. And do we need to do more to try and strategically have more oxygen in our care home settings to prevent admissions to hospital? Because I suppose away from oxygen, fluids, antibiotics, these patients aren't going to have anything else happen to them in hospital.
I mean, certainly, it seems strange where we allow some of these aspects of care in people's own homes, but it's harder to get it in an organisation. And again, it's individual governance, and we have to kind of understand, respect that. But I think it's, commissioning level may be something that needs to be worked on as to what the whole system response is, and what support these organisations are going to get if they implement these measures. I think in particular during COVID, we had problems with oxygen, actually access to oxygen, even in hospitals. So practically some of these things may be tricky in reality.
Thanks, Richard. I just wanted to touch, and this is an entire topic on its own, about ethics, and very much, dignity at the end of life for care home patients is really important, and that's one of our missions at Willows Health, to provide dignity at end of life. Now, I find it incredibly upsetting that patients, relatives, or residents' relatives in care home settings want to visit them, particularly towards the end of life. And if actually COVID spreads like wildfire anyway, do you think if there is a second wave, we should be allowing such relatives to attend people at the end of life?
I think so. I think if you view these, we're allowing bubbles, social bubbles now. I think if you view these and people go in with their eyes open, they're counselled on the risks, then it's certainly an option. They would obviously have to isolate, but with improved testing and testing availability, maybe the isolation doesn't have to be that long. It might be they could be tested 7 days afterwards, for instance, and it reduced this 14-day quarantine period otherwise. So I do think it's an option. I do think we need to explore that, because it's been a big problem. It's been tragic, really, to see people dying on their own in isolation.
Yeah, no, I mean, I couldn't agree more, Tariq. And as you say, obviously being so closely involved in a lot of the care planning and end of life work we do, it certainly has been, as you say, very, very upsetting at times to think that, someone wouldn't be able to have their relatives who have been involved right the way through in the planning of their care and that, but obviously because of the risks and infection risks of something like COVID, they weren't able to be present. So absolutely, I mean, if we were to get a second wave, I think that would be something that would have to be looked at very carefully, if obviously it can be done in a sort of safe and acceptable way for all parties.
Thanks, Vinay. So we're going to conclude for this evening. We're just going to have one final statement from Richard and Vinay in terms of a take-home message. So, Vinay, take-home message.
I think probably the take-home message is similar to what I started with, that everyone has dealt with this incredibly well from the point of view of all the different sectors involved. It's been a very difficult and challenging time, particularly as we've seen some of the statistics would show that it has affected older people disproportionately in terms of mortality risk and those in the care homes. But actually, a lot of the things that we have sort of done and implemented at a very rapid pace has really been very impressive indeed. I think sort of going forward, I mean, sort of from a care planning point of view, particularly, I would certainly say that making sure the care plans that you do are timely, as sensitive as possible, making sure they're as personalized as possible, and that often will lead to the most beneficial outcomes. And that's probably the main take-home message from some sort of my point of view.
Thank you, Vinay. And Richard, take a message.
It could be lots. I think I'm just going to say that I do think that we need to try and cement those traditional where there's sort of boundaries between primary, secondary care, primary care and care. Those are the areas we need to work at, building closer alliances, and I think that's been one of the key things during the pandemic.
Thank you, Richard. On behalf of the patients that we've been looking after at Willows and beyond, I'd like to say thank you very much, because your care in planning care planning and delivering end-of-life care planning has meant that lots of people within our patch have had dignified ends to the best that we could do. And I think that's a real achievement, despite all of the challenges we've had through COVID. And over the last 3 webinars, we've celebrated the fact that as medical professionals, we're able to adapt so quickly to the needs of our patients. And I'm really hoping we can do that collectively as a country for any second wave that comes. So Vinay, thank you very much.
Thank you.
Wong, thank you very much.
Thank you, Tariq.
And so just by the by, guys, this webinar is recorded. It's going to be on our YouTube channel on Willows Health. So our next webinar, we have either somebody from the World Health Organization talking about infection control strategy, We also have a webinar coming up sometime in July from Mr. B.Chir, who's a foot and ankle surgeon, and we're going to be talking through orthopedic cases with Professor Farhan Rizvi. Fantastic to have you all. Thank you very much for having you on board during this really summer evening. Go and enjoy what's left. Thank you. Bye-bye.
Thank you.